Thank you. And first of all, I'm very happy that Vijayakumar has again invited me for his 3D. You know, when you see your son doing very well, you are very happy. But all the more when your student is doing very well, that gives you a sense of pride and a sense of fulfillment. And that's what I feel whenever I see Vijayakumar achieving his... and I'm also happy that Ashok is here and Dr. Rao is here. And Vijay called me and told me that I gave a RSSDA honor lecture in Madurai with Dr. Shanmugavaldar, and he said, I wanted to give the same lecture here, but I didn't want to give the same lecture, but it definitely changed. So can you go back to the first slide? This is not the first slide. So actually what I want to tell you in the next 30 to 40 minutes is probably the story of, have to go back, yeah. No, let's go back. You're not going back. No, you're going forward.
You want the first slide, sir?
Yeah. Why did you go there? Usually you start from the first slide, right? Okay. I just want to talk to you about the story of how we start, research in diabetes. Because way back when I was a young person interested in diabetes, Professor Vishwanathan instilled the interest of research into me, and I had attended the epidemiology course. And one of the ways of doing research, always we think that research is something which you do in the laboratory and with animals. But there is something called population research, which I understood much later. And that's why the definition of epidemiology is that you look at what is happening in the population. And we had very little knowledge about what is happening in diabetes in this country way back in the 70s and the 80s. So that's the reason I took up epidemiology. So I'm going to just talk to you about when I did the epidemiology of the population data, we found there is major differences and we couldn't believe what is happening. And then we now, all these years, found there is a difference in the prevalence, difference in the trends, difference in the characteristics, and also in the cardiovascular risk factors, and also in the clinical profile. One of the first papers I published, you can see the year. It is in 1986 with Professor Vishwanathan and Professor Joseph Shipp, under whom I worked in the US. And very interesting. And when I went there, I found that the patients whom I saw in Chennai, in Madras at that time, was much, much younger compared to all the old guys who are seeing in the people in the United States. So what we did was very simple. I took the patients from there and patients from Chennai and then put it in the slide, and we found that there is a decade of difference in the peak incidence or prevalence of diabetes. And we published this paper in 1986 in the journal called Diabetic Association of India. The other thing which I noted was that a lot of people here are not that obese. Even today, I have many doctor patients who are diabetes who are not obese. But on the other hand, in the US, everybody walking into the clinic is very much overweight and obese. The first breakthrough was this paper, published in 1988. And you may be surprised, it is written as high prevalence of diabetes in the urban population. And it is 5%. Do you think 5% is high? Well, it was high in 1986 because the prevalence of diabetes was thought to be 1 to 2% in India, and it was only thought to be high only in the Western countries. And they thought diabetes is not a disease of the tropical countries like India, and the government didn't want to give any priority for non-communicable diseases. So this was done in a very small group of people in Kudramukh town, and we published the paper in British Medical Journal. British Medical Journal is very difficult to get it published from India, but when I wrote the paper and sent it to the editor's team, one of the editor's team wrote that this is a very important information, and then he wanted me to do something called a multiple ANOVA statistical test, which we didn't know how to do here because we didn't have good medical statisticians, and I had to get some help from somebody from Australia to get it done. And then we had number of papers, publications, including the latest ICMR study and our latest study showing that the prevalence of diabetes is exploding in our population. However, why is it happening and what is the difference? So I'm going back to one of the old papers. You remember that Stephen Hafen is a person from San Antonio, Texas, who has been involved in the San Antonio heart study, and also the person who published a very, very important paper in New England Journal of Medicine showing that diabetes is equivalent to cardiovascular disease from the Finland study. Now, he was one of my collaborators. So what we did was we took and wanted to see whether the risk factors in India is different from the risk factors that use in the white population and the Mexicans who are settled in San Antonio in the United States. And again, what I showed you was the clinic data. This is from the population data showing that age is much younger in the Indian population compared to the United States. This is a very important slide, which was published in 1997 in Diabetes Research and Clinical Practice. And what is shown here is a comparison between the Indian population in Chennai and the Mexican American population in the United States who have a high prevalence of diabetes. So what you see is that BMI is significantly high in the Mexican Americans, but there is no difference in the waist-hip ratio, which in other words, even with a low BMI, we had high central adiposity. And then I said to Steve, well, this may be one of the reasons that we have more insulin resistance. And then we did another analysis to see with the white population, and we found that for a given central adiposity, the prevalence of diabetes is almost threefold higher in the Indian population compared to the white population. So therefore, we had concluded. Then we did another study. This is Snehalada and my director of research, and wanted to see what should be the body mass index. Because even in non-obese people are getting diabetes, then the cutoff for BMI must be very different in our country. Because before 2000, we were always going by the Western standards. And we said overweight is only if the BMI is above 27 and obesity is 30. And obesity is the most important risk factor for diabetes. And we find our people have diabetes even at 23, 21, 22. So what we did was, we used diabetes as a yardstick to define what is abnormal body mass index. So what you find here is the histogram showing the risk of diabetes odds ratio in men and women. And what you find is that about 23, there's a twofold increase in the prevalence of diabetes in the population. And therefore, we wrote to the WHO that you have to redefine the yardstick for obesity in the Asian population, not 25 or 27, it should be 23. And that's exactly what happened today. Today we have a redefinition of obesity. So then we had many papers. We also found similarity with the Chinese. And what we find is a low body mass index. Even if the BMI is low, they have more fat and there is increased visceral fat. And that, I'm not going to give you all the details. Another important thing, and I'm going to show you data on that in a moment. The conversion rate of people with pre-diabetes in our populations is much higher and much faster in our population compared to the Western population. So we came to the concept that we find 90% of the people walking into an American clinic or a British clinic is obesity. But you have all these thin people in India still have diabetes. And so we wrote the concept that in the Western population, diabetes is a disease of obesity. Absolutely. And the main pathophysiology is insulin resistance. But in our patients, we have a very severe beta cell failure at diagnosis, and they have much lower body mass index. I told you about the conversion rate, and this is from the prevention trials. You know, we are one of the centers who have done primary prevention of diabetes. What is shown here is the cumulative incidence of diabetes in people with pre-diabetes in the Finnish prevention trial, US prevention trial, and Japanese prevention trial. And that is 23, 11, and 9 in the years that you see in the bottom. But look at what happened here. If you look at the Asians, Chinese and Indian, the cumulative incidence is very high. But more importantly, what I want to show you is that in the Indian population, the 55% cumulative index has become within 2.6 years. So our people, if you have somebody with pre-diabetes in your clinic, he is going to become diabetic very fast. Within 2 years, it's a 55% chance of having a risk of diabetes. So we published this paper along with people from abroad and telling that why is diabetes high? It is a very million-dollar question to answer. Well, one of the concepts which I wrote was, I wrote a term called low risk threshold for diabetes in the Indian population. Indians have a low age threshold, the threshold for body mass index is pretty low, and threshold for waist circumference is low. Even those patients who have a low BMI have high prevalence of abdominal adiposity, which gives you visceral adiposity and insulin resistance. And therefore, you also have people with a low BMI who have a high amount of fat mass. So at diagnosis, the beta cell function is much lower in the Indian population compared to the Westerners. Of course, I cannot go without telling about the low birth weight, and that concept is still applicable to some parts of India, but it is becoming different as we advance and progress economically, and obesity is coming in the main reason. Low birth weight increases the risk of diabetes and cardiovascular disease in adults. You know about the Barker's hypothesis, and classical studies from Pune by our friend Yagnik has shown that low birth weight is linked to increased risk of developing diabetes in later life. The association is independent of what other factors like body mass index, and therefore the fetal programming hypothesis suggests that an adverse intrauterine environment during pregnancy can lead to high prevalence of diabetes due to the metabolic changes. So the latest studies from the ICMR, as you know, the prevalence of diabetes 7.3 in the whole population, 10.3 pre-diabetes. Interestingly, the prevalence of pre-diabetes is much higher. One interesting feature is that you find that in the southern states, you have pretty higher prevalence of diabetes compared to especially Bihar, except in Punjab. So there is an increased prevalence. But my take on the whole prevalence of diabetes is that the prevalence of diabetes is not different the whole Indian subcontinent, because you have high prevalence in Bangladesh, Sri Lanka, including in Pakistan. Okay? All right. So we have, of course, there is a lot of heterogeneity in the prevalence depending upon whether they're urban or rural. So I'm going to take you to Tamil Nadu now, because we have been doing consecutive surveys of diabetes in the urban, town, and also in the rural population. Chennai, Kanchipuram, and a village in Pandroti. And we have been doing that for the last 20 to 30 years. And I'm going to give you some data. And this is called the STRIDE-I study, where we have found what is the secular trend. What happened 10 years ago and then later. And this is, I'm going to show you here that in the city, in the Chennai, and then in Kanchipuram, and in Pandroti, in the village. In the city, from 2006, it has gone from 18.6 to 22%. In the Kanchipuram town, it has gone from 16.4 to 20.3. So in other words, the towns in India are catching up with the metropolitan cities. And in the village, from 9.2 to 13.4. Interestingly, if you do statistics, the prevalence of diabetes has gone up high in all the population in women, but only in the village in the women, but in men it has not gone up. So it looks as if, statistically speaking, the prevalence in the population, men have almost coming to already the plateau has reached, or the highest maximum prevalence of diabetes is reaching, which is actually a good news. So therefore, if you look at the relative increase, actually it is higher in the town and in the village. It is 24% in Kanchipuram and 46% in the village, while it is only about 18% in Chennai. Now you can ask me the question, how did it increase? What is the reason? Of course, you all know that you have more food to eat, Less of work, or is it more television? Okay, let me see. Now, if you look at this, you find that a number of risk factors like body mass index, waist circumference, total calories, all have gone up significantly higher. But then you have to do much more sophisticated analysis to see which one of them is actually independently contributing to the prevalence. And I'm going to give you that. So look at this. The change in BMI is pretty significant. Change in waist circumference in all the groups have gone up significantly higher. So people are becoming centrally obese, developing big tummy. And that is the BMI going up and the abdominal adiposity going up. You may also ask a question, what about sedentary life habits? Look at this. The sedentary life habits have increased in all the populations. Maybe because of the cable television or satellite TV. Now the question is, this is called a very sophisticated Poisson regression analysis, which is the modifiable risk factor. Was it the general BMI or is it something else? And in fact, find it is waist circumference. So if you can actually target reducing the waist circumference or central adiposity by some exercise program, you can reduce the risk of diabetes. What about physical activity? It is in the villages, decreased physical activity has been another reason. So the two important reasons in villages. So this is published again in Diabetes Care. Another important aspect, interestingly, the prevalence of diabetes increased much higher in the younger population below 40 years. What is on the center is the crude prevalence. It went up by 73% in below 40 years and only by 20%. But when you do a statistical correction, it is 36% and 11%. In other words, it is not only the prevalence of diabetes is going up in the total population, more and more younger people are developing diabetes, which is actually not good because the exposure to hyperglycemia, the lifetime exposure increases and you have increased susceptibility to diabetes-specific complications. This shows you the increase in generalized adiposity among the younger population, and what you find is that it's gone up in the general obesity as well as abdominal adiposity has gone up both in the elderly people and in the younger population. However, it is again the central adiposity which is independently responsible for increasing the prevalence of diabetes in the younger population. If you look at the bottom, abdominal adiposity contributed to the increase of diabetes by 40% in the younger population, by 26% in the old population, and that was significantly different. So it looks as if our young people are getting obese, but they're becoming centrally obese. Maybe they are sitting more in front of the computers or in front of the TV. Now you may ask the question, along with the increase in the prevalence of diabetes, was there also an increase in the prevalence of cardiovascular complications? Well, look at this. There is a significant increase in both in the urban and the rural population in hypertension, in dyslipidemia, and in dysglycemia. Dysglycemia means it includes pre-diabetes and diabetes. And what you can see here is the histogram showing that the increase in dysglycemia and dyslipidemia both in the urban and the rural population. So along with the increase in the prevalence of diabetes, it is dangerous that they have a concomitant increase in cardiovascular risk factors. Next question you may ask, so now the cardiologists are telling there is an increased prevalence of coronary artery disease in India compared to the Western populations. You know that the myocardial infarction and coronary artery disease has significantly come down in the population in the United States, Israel, and also in European countries. But India, it is increasing. And one of the reasons could be diabetes. So we wanted to just see whether how much is the diabetes related to heart disease in our population. So we did a particular study called all subjects admitted to acute coronary syndrome in two centers. One in Apollo Hospital and one in another center to the low socioeconomic group. And we excluded all the people with diabetes who are getting admitted. And then we did not, these are people without diabetes at the time of admission. And we did fasting blood sugar every day during the ICU and did an oral glucose tolerance test before discharge. and those people who had abnormal values were called after 3 months and again repeated the oral glucose tolerance tested to see what is the... So what do you find? You find undiagnosed diabetes, you see new diabetes, you saw also impaired glucose tolerance. And what is the rate? Very interesting. What you see here is 46% had IGT, 38% had diabetes. Now look at this. These are people who did not have diabetes at the time of admission to the ICU. Now, when compared to the other populations, like the European population and the Japanese population, the prevalence of diabetes in people with myocardial infarction is much higher. Therefore, one of the cardiologists from United States told me this word. He said, the high incidence of coronary artery disease in the Indians seems to be glucose mediated. The prevalence of hyperglycemia, either pre-diabetes or diabetes, is so high, and that is increasing the risk of cardiovascular disease. Another question. Now, we are all worried about the population. Now we're going to come to your clinics. In the clinics, you have been seeing patients for so many years. Ashok, Lakshman, and all of you are here. When you were young, you were seeing patients. Now you are 30, 40 years of experience. Is there a change in the profile of patients that you see in your clinic? Because that will reflect what is happening in the population. So what we did was, first, we want to see whether we are diagnosing diabetes early in the population. So what we did was, we took up undiagnosed diabetes in the population and compared that with the first time being diagnosed in clinics in India. So we had 12 centers in Karnataka, in Andhra, and in Tamil Nadu, and took up all the new patients getting diagnosed in the clinics of diabetologists, general practitioners, and compared that with the undiagnosed diabetes in the population. So if you diagnose in the population, the HbA1c is about 8.3, but the average HbA1c in the clinic at diagnosis is 9.1. In other words, what is happening is that more than 8% is seen in about 68% of people who are getting clinically diagnosed, while it's only 40% in the population, which means that there is a late diagnosis of diabetes in our clinics. Sometimes, many a time, we are diagnosing diabetes after they get a myocardial infarction. That is the story of our clinical diagnosis. The next question all of us can ask is, now I told you our BMI is very low, our people come to you when they have a very low beta cell activity, but according to the guidelines of the ADA and the AST, you start always metformin. So one of my students asked me, sir, why are you always starting metformin? Metformin is only for obese patients. We are seeing thin people, why don't you give insulin secretagogue in the beginning itself? But we were not using insulin secretagogues earlier because sulfonylurea can produce severe hypoglycemia. But most of us, now we know that we diagnose patients with HbA1c of 9 and you have to start a combination. But the question was, because we see people with low BMI and high severe beta cell dysfunction, can we use an insulin secretagogue instead of metformin? Now, how will you answer that question? Do you think we can ask the British man or the American to answer the question? No, we have to answer the question. So we did a multicentric randomized control trial. This is a multicentric randomized open label study on the comparison of glycemic response and pancreatic beta cell preservation in type 2 patients treated with either vildagliptin or metformin. Now you may think that, which is better? Which is better? That's a combination. This is not a combination. I'm asking, either I'm using an insulin secretagogue or I'm using an insulin sensitizer, which is better. So that is the inclusion criteria. Now what we found was there was no difference. You see, when you do a multicentric open label randomized control trial, you do not have any control over what is happening. The answer will be the truth. The truth was, there is no difference in the percentage of patients achieving the glycemic target of HbA1c below 7, below 6.5 at the end of 2 years. So the ADA is correct, EAST is correct. anybody coming to you, you can always use metformin, no harm. In fact, even that shows you the insulin response and the insulin sensitivity change. In fact, you look, actually metformin improved insulin sensitivity, however it again came back to, so there was no statistically significant difference either in the glycemic response or in the insulin resistance or in the insulin secretion. So this is actually getting published. And there was no difference in rescue medications, because when you're doing number of centers, you have to tell the doctors, you start one tablet and the patient is not responding very well, you cannot leave them alone. So you have to do rescue medication. People who are on metformin, you add either DPP-4 inhibitor or a sulfonylurea. People who are on already DPP-4, we add metformin. So, and some of them glimepiride. So there was no difference in the rescue medication. So there is no significant, that is a result of the study. Next question, is there any difference in the number of the profile of patients that you see over the years? So in order to answer this question, somebody asked me this question from Australia, and so he said, why don't you look at, so what we did was, we took a patient's profile from the computer, because we have electronic records, in 2012 to 2018. And we did physical features, biochemical parameters, and I'm going to give you what is exactly happening. First of all, I told you that the BMI of the people in India are a little lower compared to the Western population. But what is happening is that the BMI is increasing over the years. Now we see more obese people, and this is showing the younger population. Earlier we had very old people who are coming to us. Now we also are having young people who are getting diabetes. Of course, the age of the total population is increasing, but in spite of that, you see that 30 to 49, we have 20.8 and it become 27% in 2018. So I told you in the population you get more younger people, but in the clinic also you will be getting younger people. And next, body mass index. 30 years ago, when I started my clinic, I never saw anybody above 30 BMI in my clinic. I don't remember. I don't know, I must ask Lakshmanan or Ashok. But today, you have seen patients about 30. Okay? The prevalence of people who have about 30 was 22 to 25, and you see that very obese people are coming to our clinic. Drug therapy. Now you have, every 6 months, you have got a new drug for diabetes. So are you changing the drug therapy over the years? Now what you see here is that monotherapy, dual therapy, and triple therapy. The triple therapy has gone up very high from 57 to 73. So we use multiple drugs now to actually target different pathophysiology. What are the drugs that we use? Earlier we are using not much of insulin. As you can see, only oral hypoglycemic agents. We were using 77, now it came to 67. With insulin OAD, it has gone from 21 to 30. So we are using more insulin now, which is not bad, because we are probably treating them more aggressively. And the types of drugs used for hypertension, there has gone also a big change. You can see that we are using more of ARB and calcium channel blockers. And are we doing better in HbA1c? Well, the good news is that the HbA1c above 9 has gone down from 35 to below 30. So we are treating with multiple drugs, but we are also treating more aggressively, and we are getting better results. So that's good news. So I think the conclusions are that the prevalence of diabetes has increased over time in both and the urban and rural populations in India. Indians develop diabetes at a very young age with even lower BMI compared to the European populations. For a given body mass index, Indians have higher cellular adiposity and fat mass. Of course, there is a role to play by low birth weight among Indians, which can be another factor, but that is changing very rapidly. We had nutritional deficiency in pregnancy in villages, and that has been shown as one of the factors affecting insulin resistance. Now, what is happening is that when you have a low birth weight and there is a rapid increase in body weight during adolescence, then there is an increased risk of insulin resistance and pre-diabetes. Okay, so diabetes among the young population is increasing, and you also have found that the diagnosis of diabetes is, now you may ask a question, what is the time gap between the onset of diabetes in the population and the clinical diagnosis? In order to do that, we did a paper in which we looked at a specific complication of retinopathy in people who are getting diagnosed and over the years. And we did something like weighted regression. And doing that, we found that 4 to 7 years is the time persons will be undiagnosed and walking around in the population without getting diagnosed of diabetes. And that is why when they come to the clinic, their HbA1c is already 9 to 9.5, or some of them may get admitted with a complication of diabetes like myocardial infarction or a stroke or diabetic nephropathy. So these are my collaborators. I want to stop here. I told you that I was interested in epidemiology of diabetes. George Alberti and Paul Summert were the people who did the course, WHO course on epidemiology in Cambridge, and then prevention studies, Jaco Tumulato and Peter Bennett. Some of you. Rory Holman is just retired in Oxford. He was in charge of the diabetes trials in the United Kingdom, and I was working with him on Excel trial, on global trial. And both with Rory and with Hetzel, I had the good fortune to be authors of papers published in New England Journal of Medicine. I think it's very difficult to get papers published in New England Medicine. Pablo Ashner is from Colombia. We do work on global management of diabetes. Goika Roglic is from WHO. She has helped me a lot with the WHO. I was in the WHO committee as well as we did studies for poor diabetics. Juliana, I was a part of the Lancet Commission on Diabetes a couple of years ago. Juliana is from Hong Kong. And that's my research team and my clinical team. Thank you.
Thank you.